Bismillahirrahmanirrahim. Assalamu alaikum. We're just setting up at the moment. So I'd just like to introduce some, as it's our first ever webinar, just try to introduce strong support where and what we do, inshallah. So let me see if I can share the screen. So hopefully you can see that. So at the moment we're very grateful to be joined by actually one of the first videos I sent to our men's group and strong support was Andrew's, in which he thoroughly goes through the different types of therapies which are available. So as you can see, there's the website is here. You can see if you can see that. Yep. You can access, for example, we're discussing counseling at present. So we have details here for coaches and counselors, and I've just added Andrew's details. I hope he doesn't mind over here. So you've got these details if you wish to contact him. He has practice. I believe he's in 4 different practices, is that's right at present. And I know he does some online counseling, so please take use of this opportunity. And in terms of so what strong support does, we've got different resources, for example. So we've got books which we recommend. So part of it psychology, and also for family, because I have a lot of family members asking me what to do if a family or a close member, for example, is struggling with unwanted same-sex lust. Similarly, we have a Facebook group. So this is the one which I was speaking, a separate group for men and women, as well as in terms of our weekly programs, we have the support circle, and the support circle runs every week. At present, because of the month of Ramadan, we were running slightly earlier at the time of 6 to 7. Have of brothers who, at the moment, we have a brother circle who kind of benefit from that weekly support from that a video conference offers. We also have something which is free at the moment, which is most of the brothers in London, about 10 or so. We have a weekly circle on Sundays, which is hopefully after the coronavirus madness, we can then set up a local group for that. At the moment, we're virtual. So the intent is to create a local group, hopefully, once social distancing guidelines allow. I also wanted to introduce, before introducing Andrew, to introduce his YouTube channel, which I think is really, really good. He calls it PsychoBible. That's really nice. And there's a wealth of information here in these playlists, like on different topics. And it's you know, a lot of people come to me and they say, Ali, is there any resource? Is there, I'm completely new to this, I'm new to the topic. Is there any, you know, thing that you recommend, which is easy for me to watch. And then honestly, there's so much here. I was actually looking at some of the playlists here, and I was looking at what Mike, because we've recently been looking at Mike Davidson's series, which he's also got here. So so there's almost a wealth of information which is here, and it's really unlike, I don't see anyone else doing it. IFTCC and the Alliance, because the Alliance is like, oh, you can come to California. I'm like, I'm in the UK. I can't really reach there. So there's clips in there from the Alliance reviews, which I find very, very useful. I mean, using communication, hopefully of the nice type, from people.
I get some debates, but
yeah,
I lost some of my debates in a way, because I used to just have all my videos on my personal channel, and then I created a brand account called PsychoBible. And when you switch over to a brand account and you move all your videos over, any comments you made as Andrew, like that I made as Andrew Rodriguez, I lost all those comments. So you might go through some of the comment sections, like say my one video, my biggest video is the one where I was speaking at a college about therapy for unwanted
Oh, that's the one we watched. Yeah.
And you'll see there's a couple guys in there who tried to debate me and stuff, but now my comments are gone. So I've been deliberating, like maybe I'll go and plug, because I took screenshots of my comments before I transfer everything over. So I know what I said word for word. I can go and retype those all in there if I wanted. I might. We'll see. It might, some dude who was debating me 4 months ago is going to get a notification that I replied to his comment, and it'll be kind of weird. So I haven't done that yet. YouTube, but if you read through it, you'll be like, wait a second. Here's this guy saying all this stuff, but there's no reply. Why is he going on and on? Just deleted it.
No, I really, commend your courage. I think even at this climate, it can be difficult to speak for equality, to speak for therapy equality. And, the fact that YouTube's allowed you to have that brand channel, so people, have an open mind. We welcome people of all different views, and we just are saying, just let's have an open discussion on this. And I think your channel is really good in that it offers that. It has one of the voices which unfortunately is not really heard nowadays in the media, and the other side of it. And I spoke to Andrew, and we had a really nice conversation, about an hour, and we were just discussing like certain different things. And I'm quite new, so I'm learning counseling. I'm training at the moment, and it's interesting to see how much of this stuff has psychodynamic roots, which we'll kind of go into, but also new approaches have probably come into, which take a more of an integrative approach now. So we're seeing a holistic kind of approach, whether it's CBT methods or even Rogerian kind of humanistic methods. And hopefully we kind of go a bit into that, so people are aware of what the different types of therapy which are available, and what for people who are tuning in to see, okay, what is actually accessible. So I'm gonna stop the share from here, and I'm gonna see if you can, I don't know, so there should be a share screen option.
Oh, it says, do you see that? I'm not sure. Okay, it says host disabled participant screen sharing.
Okay, let me just.
Do you want? I mean, that was one benefit of me.
No, so
sending you the PowerPoint.
So if you try, if you try that again, see if it
Oh,
changes.
okay, there we go.
Yeah, I'm new to this as well.
Oh, good.
Forget that.
All right. Let me go back to here. All right. Okay, cool. Now, do you want to start right here, or do you want to? It's now 12 o'clock, so I guess we're starting. But I figured you want to.
For those of us, I think most people just joining in now as it's 5. So just to introduce, so Andy, we say
Yeah.
Andy because I'm a Brit, right? And I've got friends that we call them Andy.
Okay.
So Andrew's joined us he's a Christian psychotherapist. And as we mentioned, he works in 4 different practices. And hopefully we can have a interactive session. I mean, what do you think, Andy? Do you think we should, how do you want to take questions? Do you want to take questions at the end, or do you want
Probably,
to?
yeah, if we could do them at the end. I
Okay.
guess I might have difficulty, especially since I'm new to doing the webinars, tracking the questions. So would you be okay?
Yeah, I'll be able to do that, and I'll help you.
So I would say if people could maybe wait until maybe like half an hour and then start submitting the questions. That way I can go through at least the basics of the presentation, and then we can field questions for the last bit there. And that way no questions will get lost if they start asking stuff right away.
Yes, and if there's something that we can't cover in this webinar, then send me an email, send Andy an email. We'll definitely make sure that nothing gets, everything gets answered, hopefully. And then just on logistics thing, you'll see there's a Q&A kind of button at the bottom, and then you can ask questions at any time for that. And at the end, I'll go through that list. Also, if we have a lot of questions, then you'll see there's a button which says raise hand, and then you can raise your hand and actually join in as an audio participant, and then you can ask your question by audio. So then that's how we'll go. And there's also a poll, which I'll do right at the end, just to see, just get a bit stats from you guys, which would be helpful for us. So yeah, that's me done. Over to you, Andrew.
Okay. All right. Well, thank you for having me on, and it's an honor and a privilege to just kind of just discuss this stuff with you guys. And it's really cool that this is the topic for your very first webinar, or at least the first of many new ones, if you're really like giving this a good push after this, because hopefully what we'll do is just lay down some groundwork of what the trends in therapy for homosexuality, same-sex lust, same-sex sexual behavior, however you term it, what those trends have been in the past, where they're going, what they currently are, so you can get a good overview. And then from here, that's a good launch pad for you guys to get into a whole bunch more topics. So I figured first I would just go over some of the briefly over the history of therapy for this issue. But first, I guess actually before that, let me just comment real quick on the terminology. So this presentation, actually, I just modified a lot of parts of it from another presentation I did when I was speaking at a university on therapy for unwanted same-sex attraction. Now, I was talking to Ali, and you guys prefer to use the term same-sex lust, which actually I think is excellent, because there's so many different ways you can term the issue we're dealing with. You could call it homosexuality. You could say same-sex sexual attraction, same-sex attraction. I've sort of gotten in the habit of just saying same-sex attraction, because for me, even though it's still pretty long, it's one of the shortest ways to say it. Other people say same.
You can say SSA. We won't hold it against you.
Or SSA for short. I got some people who they're very, very particular about it. Someone, nope, it's same-sex sexual attraction, and I'm like, that makes sense. I agree with that too. Or Carolyn Pila would say same-sex attraction experiences. because she's coming from and I'll get into that with her approach. And there's same-sex eroticization, because we want to make the distinction between the attraction or the longing for connection to members of your own gender or sex, and eroticizing those desires and those longings. So, and also, what pretty much all of us are in agreement is we don't tend to say things like gay to straight, or lesbian to straight, or because we're not thinking in terms of these clear-cut boxes that people are in and that you just sort of are. That to say someone is gay, to say that there's something about them that makes them a certain way, and that's just, it's we say the word immutable. It means unchangeable. They're born that way and they cannot change, and that's just how it is. So when we talk about attractions or lust or eroticization, we're talking about, well, these are the experiences that someone has, and experiences may or may not change. So that's what we all sort of share in common. So we're not talking about changing people at their fundamental core as much as helping people make choices that better fit their values. So if they're experiencing something that they disagree with, or that they do not wish to actively engage in, then they have options available to them. Mm-hmm. So the therapies that we are involved with or advocate for are not anything that's coercive. We're not imposing our worldview on others. We're not forcing people into a type of change that they don't actually want, or and I'll get into some of those things that to avoid and watch out for in some therapists. But we're simply advocating for people having options in dealing with something that they find as incongruent with how they see themselves and their value system. Okay. So I do have a PowerPoint. I sent the entire thing to Ali. Because I'm not going to go through the entire thing today.
We'll send this at the end to all participants, so everyone has a copy.
Yeah, so don't expect me to go through the entire thing. I'm going to blaze through parts of it. And of course, I'm an American, so I'm coming from mostly an American point of view on this. I know, and I know it might sound arrogant to say, but most other countries are sort of following America's lead when it comes to this issue anyway. Mm-hmm. So as the American Psychological Association or American Psychiatric Association makes certain policy decisions, those really inform what a lot of other countries do. Even though now we're starting to see a lot of other countries take more of a lead in their opposition to our work. So even going further than we've gone in America. All right. So going back to like really just the traditional modern psychology, homosexuality, or the habit or the behavior of engaging in sexual acts with another person of the same sex has been considered a disorder for decades. And if we understand the waves of psychology and treatment, we know that psychoanalysis and the other psychodynamic theories were the first wave. And so they were treating unwanted or ego-dystonic homosexuality, the attractions as well as the behavior for decades. And they viewed it from as a developmental problem, more of an adaptation from unmet developmental needs. So something going a bit askew with the individuation process, in particular for boys. So mostly you see writings from some of the early psychoanalysts dealing with men with homosexual behaviors or attractions. And so they look at the family unit and how they're what we call the classic triadic relationship. I'm not going to go into too much in depth with that right now. Then as the waves of psychology changed, then as long as this was still considered a disorder, then there were new approaches being used. So in the 50s, 60s, 70s, we had behavior therapy really take over. Is that sort of overtook psychoanalysis as the preferred psychological approach to therapy. And so with that, there became more behavioral techniques to approach homosexuality. And so that was treating more that behavior. As long as we can get a guy to enjoy sexual contact with the opposite sex, then there, the issue's been resolved. And so just as with other sort of conditions that someone might have where they are dealing with an unwanted impulse, then some behavioral psychologists would start to use aversive techniques where they guide the client in using techniques or strategies that would associate pain or discomfort with the impulse that they're trying to end. Or they would also do, and that's in addition to other very classic behavioral techniques like reinforcement, reward, just modeling. So ones that aren't aversive or painful. But yes, there was a point up until the 70s, really, when aversive techniques were being used. And that's primarily all in a secular setting. So oftentimes those of us from who are religious counselors were being lumped together with those from the past who use aversive techniques, and there's really at least not any documented bases for that, at least not among professional Christian psychologists and therapists. But anyway, then what happened is as society changed and the gay rights activists began influencing the American Psychiatric and American Psychological Association, there was a very large push to change homosexuality as a disorder and disregard it as a disorder. So 1973, this is a long story short, there's a lot that went into it and led up to this, but the American Psychiatric Association, which I apologize, we got American Psychiatric and American Psychological Association, both APAs. You know, with all these smart people, you'd think they would have come up with better acronyms for their organizations so they don't get confused. But there was not a consensus about removing this as a disorder. And for a while, they allowed homosexuality to stay a disorder if it was ego dystonic, meaning like if you had the same-sex lust, but it conflicted with your view of yourself, it conflicted with your value system, then it could still be considered a disorder. But then that was removed with one of the updates to the Diagnostic and Statistical Manual in 1986. So, and since then, since the 70s, they've been fighting against what they consider homophobic therapies. They would consider anyone who is helping someone change in their attractions, change in their behavior or identity from a homosexual one, then they are practicing a homophobic form of therapy, and they are propagating stigma against homosexuality. So really, if you're going to be doing this work, you're really being countercultural, because now the culture in general has changed so much that they pretty much will oppose anyone who is looking to change in their in the broader sense orientation, which includes that it's an umbrella for your desire, your sexual desires, your identity, your behavior, your relationships. All right. So even though as the culture was changing, the world of psychology was changing, that didn't change the fact that there were people who were leaving homosexuality, or they were finding that they just weren't satisfied with homosexual relationships and behavior. And so we were finding in the mid to late 70s, a lot of them were leaving it and through religious experiences finding what they would say freedom, and freedom from either the behaviors, the relationships, and finding a new sense of inner peace from a conversion experience, from actually surrendering to God, from finding healing from their new relationship to God, and being accepted in a community of fellow believers. And so there was a religious movement to help people who were affected by unwanted same-sex attractions and behaviors, and that became what led up to different ministries for people leaving homosexuality. And so you had Exodus International form. It started off as like a support group, And then it grew. And so Exodus became this international umbrella organization for member ministries and counselors and pastoral ministers all over the globe. And so they're primarily coming from a religious approach. Now, that's being said, though, a lot of them were informed by psychology, and the effectiveness and level of professionalism or training in each ministry would vary. Okay, so to be honest about that, it did vary, and there you could look through the history of Exodus, and there were some ups and downs, no doubt about it. 1991, NARTH formed. NARTH is or was the National Association for the Research and Therapy of Homosexuality, and I'll get into that in a bit more. While that's happening, more and more, and so with NARTH, that was psychologists and therapists who wanted to provide options for people who wanted to deal with their unwanted same-sex lusts or attractions and behaviors in a way that wasn't just purely religious, but was informed by current mainstream psychological approaches. And so one of the co-founders was Joseph Nicolosi, the founder of reparative therapy. And as that's happening, as the NARTH is developing, you have APA condemning that form of counseling. And usually it's based off a strongman. Then you have other developments like 2009, the APA Task Force Report on Appropriate Therapeutic Responses to Sexual Orientation. And it's this huge volume. I forgot to bring it with me, but I have a copy of it myself. And with that report, then different states would cite that to pass bans on therapy, particularly for minors in multiple states. 2012, the first one was passed in California, because that report concluded at the end that there's a chance or risk of harm for people trying to change their orientation. However, when you actually read the report, you'll see that they don't provide the studies of rigor to support that claim or conclusion that they made at the end. 2014, then the APA has their Handbook of Sexuality and Psychology. It's like 2 volumes. It's huge. But I will point out one thing here. Dr. Laura Haynes from the Alliance for Therapeutic Choice and Scientific Integrity, she has a copy herself. She pores over this research, and she's pointing out how Dr. Lisa Diamond, who's a lesbian psychologist and was one of the chief editors or co-editors on this APA handbook, says herself that sexual orientation does not come in 2 types, exclusively homosexual and exclusively heterosexual, that are rigid and unchangeable. And so she's telling activists to stop promoting the myth of born gay and cannot change. So it's right there in the APA's own handbook that there's no evidence anymore to support this claim. So anyway, that's just some of the latest developments in the world of psychology. Now, say you're someone who is experiencing the attractions or the lust for the same sex, and it's a problem for you. What are your options? There are 3 main approaches. And these are very broad categories, okay? There's gay-affirmative therapy. That would be the officially approved approach of pretty much the whole secular counseling world. The APA, the American Counseling Association, the World Health Organization, all of them would approve, because they are still coming from this point of view, even though the research doesn't back it, that homosexuality is something that you're just born as, and it's unimmutable, can't change. So the safest thing for you to do would be to come to accept yourself as homosexual, as gay, lesbian, bisexual, whatever you want to identify. Then there's sexual identity therapy framework, or SIT framework. This one is coming from an approach that doesn't really make a case about how homosexuality develops, and will use a lot of the same terminology as the secular world. It focuses more on identity and behavior, so not really focused on changing the attractions or the lust. And then there's what the world will call sexual orientation change efforts, or SOCI. That's more of a legal term, and it's a very broad category, okay? It's any effort to modify homosexual attraction, identity, lust, behavior, relationships. Now what you're seeing even more is instead of using the term associate, they're using the term conversion therapy. And so it's become a bit of a pejorative term, this idea that, oh, we're trying to promote a therapy where you just change. I'll get into that a little bit more. But under this umbrella of SOCI, that includes almost any sort of effort, like the ex-gay ministries or religious approaches, therapeutic approaches like reparative therapy or any other mainstream approach, any other change-oriented therapies, which we're now calling safety. So I'll go over those more in depth. Gay-affirmative therapy is explicitly not neutral. Like they make a point to not be neutral in whether or not someone should accept a gay identity. So for you to see a secular therapist and say you're questioning whether or not you want to pursue homosexual behavior relationships, and you see a therapist who's coming from this perspective, they're most likely not going to let you have the space to figure out for yourself which path you want to take. They're going to purposely question any assumptions you have about homosexuality and help you come to accept it as a good thing. And then try to enlist you in combating bigotry in the world. So this is explicitly their goal. You can look up trainings on gay affirmative therapy. So it's not an approach for people who are just questioning and want a neutral perspective. So, and then when it looks at, well, all the other comorbidities that we find among people with same-sex lust or attractions, it would say that all those things, the depression, the increased drug use, the other trauma reactions, anxiety, alcohol use, the promiscuity, they say all that pathology related to homosexuality is due to internalized homophobia and stigma from society. So the goal of therapy is to re-educate the client, then as they come to accept and embrace a gay identity, to help them re-educate their family, their friends, and then for the client to become an advocate as well. And one of the main methods they'll use is hypothesis testing. So say, well, I have homosexual attractions, and I was raised to think that that's wrong, and that is evil. And so my therapist would be like, that's evil. Do you know anyone who's gay? Yeah, I got this guy at the grocery store, the cashier I see all the time. Well, does he seem evil to you? No, he seems like a pretty friendly guy. Well, maybe homosexuality isn't evil. And so it's just like, use hypothesis. Do you know anyone else? And so this is why there's such an effort to change the in media representation is so key. If you notice now, any major new TV show, there's always a representation of an LGBT character. So there's a concerted effort to change the image so that we have more people we can look to and like, well, yeah, this character on TV show that I really like, they're gay. Well, then this must not be so bad. So if we get to view positively other people who are engaged in homosexuality, then that changes. And so they move through what they call the coming out continuum. Because once again, they have this view, you're born gay. So it's not a matter of you choosing homosexuality or even a matter of you just embracing homosexual behaviors, but this is what you are. So you're coming out, you're embracing it, and you're becoming who you truly are. That's the perspective they're coming from.
Yeah, I think it's just to add to that, it's so odd when they term conversion therapy, or even if you want to call it conversion, then why don't they say, oh, it's conversion the other way as well? Because there's no neutrality over there. So if you're saying we're converting people or we're forcing people, then why is it? And it's yeah, absolutely. And in the UK, they've published a memorandum of understanding, which is our equivalent to APA, where you have Stonewall, which is basically signed. And it actually says in the memorandum, no one sexual sexuality should be imposed over another. So one sexuality isn't better than the other. But then the hypocrisy is when you ask for therapists who can help you after reading this memorandum, or they refer to, they're all gay affirmative therapists. So it's like, hang on, you're saying that we need to keep a neutral perspective, yet the therapy that you're referring us to isn't neutral at all. And in fact, it will it is very political in its nature, where it will only listen to one form of kind of one worldview and not listen to another.
Yeah.
So yeah, thanks for that.
Yeah. I'm sorry, I just checked the time, like, holy crap. So I'm gonna have to blaze through a bit more of this. So let me just briefly, I already mentioned a little bit about sexual identity therapy. That was developed by Mark Yarhouse and Warren Throckmorton. They try to be neutral about the causes of homosexuality. Their main concern is just helping people live congruently with their values. So, and not focus on changing the attractions, the lust itself, but more, okay, especially they're working with people who may be married already to someone with the opposite sex, but they struggle with the behaviors. They would call that a mixed orientation marriage. And they're going to use a variety of therapeutic approaches. It's not like this is an actual therapeutic approach. It's more of a way to figure out what the goals of therapy are. And so that we might be using a lot of cognitive behavioral approaches, maybe some postmodern and client-centered approaches. So I'll just go on from there. There's some good aspects to this. I also have some criticisms of this. I just would say it doesn't go deep enough in some ways. All right, SOCI, like I said, very broad term, and it can vary. Who practices SOCI? Well, it could be a pastor, it could be your rabbi, it could be your imam, it could be it could be anyone. It could be your best friend. It could be yourself. They're counting things as SOCI or conversion therapy, almost anything. If you go to a church where they teach that homosexual behavior is wrong, they consider that going to conversion therapy. So it's become almost an untenable term to use any longer. Who can practice can be a professionally trained or untrained provider, licensed or unlicensed clinicians. So it's just a lot of things that fall under this umbrella, because it's just sexual orientation change efforts. What's an effort? It could be a self-help effort. It could just be you praying to God, and they consider that SOCI. So not a very helpful term. And then, of course, there's the conversion therapy term, which there's a lot of us that are trying to distance ourselves from that term. I'm not going to get into that a whole lot right now, because there's a bit of a debate to be had there. The world has used it so much that we can't really avoid the term. My main approach is just, okay, if I hear someone use that term, I want to know, well, what do you mean? Are you referring to actual therapy, or are you going back and using things like self-help, or going to a church and hearing a preacher talk about homosexuality? Like, that's not therapy. What they consider therapy just is ridiculous a lot of times. All right, then you had the ex-gay ministry movement. I went into that briefly before. I'm going to move out of that and continue with NARTH and the Alliance. So like I said, 1991, the National Association for the Research and Therapy of Homosexuality formed. And this was all about promoting professional therapy approaches, not necessarily religious ones or necessarily Christian ones. So we've had a lot of Mormon representation. We've had some Jewish representation. I've seen some Muslim representation at the Alliance. A couple of years ago, there was a guy from UAE at the Alliance conference. And then 2014, they changed the name of the NARTH to the Alliance for Therapeutic Choice and Scientific Integrity, which is a mouthful. I will call it the Alliance for short. You can also say ATCSI. It's not a very tenable name. It doesn't roll off the tongue.
Well, we have the similar. We call it IFTCC because it's quite.
And then
difficult.
yes, and then 2018, Mike Davidson, who's also on the board of the Alliance, he helped found the International Federation for Therapeutic and Counseling Choice, and so IFTCC. So the Alliance we're allied with the IFTCC, and so you see a lot of crossover. A lot of clinicians and board members involved with the Alliance will also go to the IFTC conferences, and Mike Davidson's doing excellent work there. I got to say, he puts the Alliance to shame with some of the videos he puts out. We really got to catch up to him with putting out more content. But check out his channel as well. He will post the lectures from their conferences. So if you're not able to make it to one of their conferences, you can learn a lot still from what they post. So 2016, because of the confusion and just all the propaganda regarding the term soci and conversion therapy and even reparative therapy, a lot of people have taken Nicolosi's approach to dealing with same-sex attraction, and they dragged that through the mud. And they were saying, oh, this person's a reparative therapist, this person's a reparative therapist, when they weren't. They weren't actually using Nicolosi's approach, nor were they trained adequately in his approach. So the Alliance adopted this term safety, sexual attraction fluidity exploration in therapy. It hasn't quite caught on yet, but I will try to refer to that when I'm talking about approaches for unwanted same-sex lust, attraction, behavior, identity being conducted by professionally trained therapists who are using mainstream counseling approaches. So it's an exclusive term, but it's inclusive of multiple approaches, okay? And they make a few points that change in attraction is never guaranteed. And if it does occur, it's understood to occur on a continuum. So we're not putting this idea of gay to straight, that you're going to change categorically. That was never one of the claims. Even Nicolosi would say that his therapy was never for a categorical change. He would always say things like a third, a third, a third. You know, a third significant change, a third almost complete change, a third no change. And you know, the factors for that could vary. And there's various approaches within safety, and they may or may not pathologize homosexuality, meaning like the different approaches that may be used within this umbrella may make it a point to consider homosexuality a disorder, and others may not. So there's a variety within this approach. So before we go into some of those main approaches within safety, just a few things to look for in a therapist if you're looking for help in this area. I posted a link in this PowerPoint to go to the Alliance's clinical practice guidelines. These were updated in 2018. So I would advise you guys to look there. Now, these are not binding in any way, but these are very wise clinical suggestions and guidelines that anyone would be good well follow, whether you are looking to do this type of therapy or if you're a gay affirmative therapist normally. I would advise you to check out these guidelines. And I would say the therapists I know in the Alliance, which I'm familiar with pretty much all the big names there, they would follow these guidelines. And they're very much about some of the points I make right here. Now, if you are not necessarily looking for change in your attractions or behaviors or identity, but you're more questioning, you're not sure what to make of the experiences you're having, I would advise finding a therapist who is non-directive, non-judgmental, and who's going to be inquisitive, who's going to help guide you through exploring your options very freely, as well as inquisitive about, well, what do you think started the attractions? You know, it could be that you just think you're born that way. Okay, fine. It could be you think it's because you were molested. Well, hey, that might be worth looking into. It could be because you think other experiences in your life contributed. Maybe there's a plethora of contributing factors. What a gay affirmative therapist would normally won't do is ask the question. That's one thing Nicolosi told me. They never ask the why question because they already have an assumption about why you have the attractions. And so if you have other experiences in your life like trauma, they'll just consider that incidental. It's just, well, you just happen to have had trauma. And maybe it's because, maybe your dad beat you up because you were gay. Instead of thinking that maybe the attractions developed because of the trauma with your dad. They don't go there at all. So even though you may not be a therapist who would then help the client resolve the underlying issues or resolve the behavior that is same-sex directed, at least be inquisitive. Ask the question, because the client most likely has the questions but is afraid to ask them. Okay. The other thing though, find a therapist who supports client self-determination. The bans will not hold if enough clients who are looking for counseling from a professional therapist but now are being denied those opportunities, if all those clients rise up and say, no, I have a a right to therapy that fits my goals, especially when you consider actually that homosexuality is not a disorder. Then we should treat it like no other, something like a relationship problem. Because if, say, I'm having marital problems, I go to a therapist. It's the goal of that counseling is determined by me, as my spouse or partner, and the therapist, what the therapist is willing to help me with. It's not there's not a guideline. No, you must counsel them to stay married, or you must counsel them to get divorced. The goal of that therapy is up to me. So what the opposition to our work is trying to do is have their cake and eat it too, by saying, no, it's no longer a disorder, so you can't treat it and get reimbursed by insurance companies. But we also are going to still tell you how you should address it. It's like, well, no, if it's just a relational issue now, it's up to me. It's a lifestyle issue. So me as the client, I have a right. And so all the major counseling, I'm sorry, go ahead.
No, absolutely. And, like we're learning now in terms of, when you're counseling, they're saying ethical framework, each body that you has an ethical framework.
Yes.
Well, the APA and both, the Alliance and IFTCC have the same guidelines. And these guidelines, as as you've shown here, are putting self-determination. They're putting a neutral perspective forward. They're saying we're not forcing the client. The client's coming forward and they're saying, I want this. They're not at, it's, if we had a client coming in, they're saying, oh, we're not sure actually whether we want this or we want not, then that's a different issue. But when you have clients which are deeply motivated in this strategy, it's their self-determination which is driving it rather than the therapist. And I don't think you could be in any type of therapy, let alone same-sex lust, where the therapist is right. It just doesn't work, right? It just wouldn't work. You wouldn't, if you're doing that therapy for a while and you're saying, well, I agree with what the therapist is saying, there isn't a strong therapeutic alliance there at all. So it's something that's bound to fail. And it's interesting to say, okay, we have our ethical frameworks. What are the ethical frameworks for the gay affirmative therapists? Do they purport a neutrality in which if a client comes to them and they say, oh, we don't identify with this, would they then refer them on to someone who can help? Or would they then say, it's immutable, as you said?
Yeah. And I was also know your rights. If you go to the APA's website, if you go to American Counseling Association, I don't know other countries, but they will have the client rights. You'll have the ethical guidelines for that practice, for psychology, for psychotherapy, and all of the organizations have as a principle, one of the ethical principles, client self-determination or client autonomy. So that becomes your basis for appealing to obtaining therapy that matches your values. And if enough clients start rising up and demanding that they have access to therapy that supports their values, then that's where we'll see change. And I would add too that, and even though I probably shouldn't say this yet because I don't know if there's enough research done on this, but I would say the best therapy is when the therapist genuinely supports your values, when they genuinely agree with your goals, not just, well, I'm going to be neutral, so you just you choose your goals and I'll help you out as best I can. But when that therapist genuinely agrees with them, even if they don't necessarily express that in such a enthusiastic way, because you also don't want the client to become dependent on your enthusiasm and your affirmation. But as long as, when you really agree with that, where they're going, that influences the topics, and influences some of the suggestions or insights you might have. So in very subtle, maybe unconscious ways, that influences the therapy. Whereas if you disagree, you're going to undermine that therapy in some way, even if it's unconscious. So that's my perspective on that. You want to make sure you have a strong therapeutic alliance with the therapist. One thing Nicolosi told me before his passing, they had made a lot of modifications to reparative therapy over the years. And he was telling me with the innovations that they had, especially with a lot of their trauma-based approaches, he was like, if we don't see significant growth within, say, 3 months, then that tells us there's something wrong with the therapeutic alliance. that the therapist and client aren't connecting properly. I would advise having a therapist who's familiar with trauma and addiction, especially when you get into some of the reasons why. What are some of the contributing factors? There are some that may require more expertise in trauma and addiction. Not always. Some people may have developed their attractions kind of later in life, and it's more due to other circumstances that maybe the addiction and trauma education may not be as necessary, but I would say that's a good thing to look for. What to be aware of. So what to watch out for. You definitely want to be aware or be wary of any therapist who makes promises or guarantees about the outcomes. All right, you follow this program, this model, yeah, we're going to get rid of those same-sex attractions. You're going to start having relationships with the opposite sex. It's going to be amazing. You're going to feel like a whole new person. It's going to be a distant memory. Watch out for big claims. Okay, like I said, we understand that if the attractions change or the lust change, it's on a continuum. Okay, you know, we've always had a realistic perspective on this. There's maybe some fringe therapists or ministries that had very wild claims. I would watch out for those ones. So watch out for someone who's imposing a model or an explanation. Yes, some of us are really big fans of our approaches. And so I mostly agree with the developmental model that Nicolosi developed over the years, and for explaining the origins of same-sex attraction, particularly in men. But I understand that model may not always fit. Now, at the same time, I'm not going to go into too in depth, because I would also say that it often does fit in ways that may not be conventional. So sometimes I get a client who's like, no, this doesn't fit me at all. I had a great relationship with my dad. Once you get to know them more, start finding out there's other ways that it fits his model, because his model included not just the triadic family, the overbearing mom, the distant or rejecting dad, and the sensitive child, but his model also included ideas of there being later contributing factors, so different stages or types of homosexual development. But either way, don't impose the model. Hear the client, listen to their story, be open to modification of your explanation, and don't enforce that, okay, we have to do it this way. Sometimes it doesn't work that way. And watch out for someone who's got an emphasis on external change. This is kind of a no-brainer at this point. If you see someone who's just encouraging things like, oh, watch straight pornography, male-female porn, or they're trying to get you just be more manly, just, all right, you grew up probably not really into sports, which is a stereotype of guys with same-sex lust, then join a rugby team, join a football team, play basketball, start toughening up. Or if you're a woman who one of the typically butch lesbians, all right, wear more dresses. And so it's all about changing the exterior. And there you go, there's change. And so watch out for that. That's a big red flag. Watch out for dual relationships. If he's a pastor and your therapist, especially then if they want to be your friend and therapist. There's some guys, especially if they've gone into this type of work because they came out of homosexuality themselves, they sometimes can be triggered themselves and have some blind spots. So watch out for that if they start violating personal boundaries. All right, so the big daddy was reparative therapy, developed by Joseph Nicolosi. Originally began and I would also add with Charles Socarides. Charles Socarides really used just very much classic psychoanalysis, very Freudian in his approach. And so that meant going to the therapist's office on the couch multiple times a week for probably 3 years at least. Nicolosi was more willing to modify things. Started off very psychoanalytic, very psychodynamic, but he was willing to change things as he got to know the clients. And so whereas a typical psychoanalyst will be that blank screen, like I was trained by a psychoanalyst. And so he would ding me all the time on my, what he calls verbal units. As you can probably tell, I'm a big talker. so I'd be very engaging with the client in my sessions, and I'd record my sessions for my supervision, and he would his head would explode because I talked so much with the client. And it's something I've curved over the years anyway, but his ideal session as a psychoanalyst would be where the therapist doesn't say a word. But what Nicolosi found was clients that coming in for this issue really needed engagement. And it makes sense considering that this is a relational issue and it's rooted in attachment. So they need to sort of develop a new attachment with the therapist. And he also developed or incorporated more trauma-informed approaches over the years. Now, of course, like I said before, reparative therapy got conflated in the media with other forms of SOCI or just conversion therapy. But you notice reparative therapy has a focus on treating the shame and attachment loss that he considered at the root to the same-sex attractions and behavior. And the way he would access that is different than most modern therapies, because you go to most other schools these days, you're going to learn probably cognitive behavioral therapy. So you got like the three components of the soul. You got your mind, will, and emotions. You got your thoughts, behaviors, feelings. Most therapies these days are going to focus on the thoughts and the behaviors. That's cognitive behavioral. You know, change your thoughts, change your behaviors. The emotions are one we can't really change. But an affect-focused therapy is really going to try to focus on the feelings in order to change your thoughts and behaviors. And that was where Nicolosi came from more. By doing body work, by accessing your feelings through your body, you know, where are you feeling, what are you feeling right now? And he's like, well, I feel like this radiating heat in my chest. Like, okay. And he would know that's anger. Like, oh, I feel like this. And like, oh, there's shame. Because you'd be like, what's the circumstance that I triggered this? And then as you feel like feel the feeling, stay in that feeling. And then with the body work, okay, when did you feel that in the past? And you go back to history and be like, oh, I remember a time when I was younger and my dad berated me, or whatever the case was. I like, okay. And you grieve that feeling. You go through grief work. So it's healing the emotions in order to heal the other behaviors that became sort of branched off of that. And so he would also use other trauma-sensitive approaches like EMDR, eye movement desensitization, and reprocessing. And this really was, over the years, more influenced by his son, Joseph Nicolosi Jr., who then, in 2018, he copyrighted or trademarked reparative therapy, and he took the more current version of it and changed the name to reintegrative therapy. And he changed some other things about it. So that way, he'll say reintegrative therapy is a therapy for treating addictions and trauma. He says it's not explicitly a therapy for changing same-sex lust or changing homosexual identity or behavior. So, because if anything, you say that the change in the attractions is a result of dealing with the underlying addictions and trauma, which is pretty much what his father would say, but his dad had no problem saying that the goal is to change the attractions and to develop heterosexual potential. But his son now is saying that, well, we're going to avoid some of that language and we're just going to make it so this is a therapy for anyone. And really it is, because prior to him making this change, when I first learned about Nicolosi's approach, I'm like, oh, this approach that he does, this works with my clients who just have heterosexual sexual addiction and pornography addiction or any addiction. So I started working with using a lot of the stuff I was learning from Nicolosi with my other clients. Now, the other thing that Joe Jr. did was take reintegrative therapy and make it more of a standardized protocol. And so there's, instead of like more of a free session where the client comes in and then you just sort of talk a little more freely, it's more, okay, here's a protocol, this is what to expect in the session, even though sometimes you might not be able to get through every stage of the protocol. But you're going to examine the activating event, identify the associated feelings at the peak. So say there's a moment of extreme attraction to the person of the same sex. Okay, where's that peak experience? And stay in that feeling. And then he would do what he calls a gazer inversion. So imagine yourself stepping outside your body and then looking in your eyes. And what do you see? And he would see like 3 levels of feelings. And it might be like, oh, I see euphoria. But then I see I see some fear, like, and then I keep looking. All right, stay there, go further, and then I see pain, and so you see that there's something else, some other issue that is underlying that attraction. And then he would relate it to the past, and that's where then we would use one of the trauma-focused approaches. So using self-compassion via either EMDR or mindfulness, or now say other reintegrative therapists like David Pickup and Robert Vazzo have been using image transformation therapy. And then after going through that, working through that underlying historical trauma, then revisiting that activating event and reassessing the reaction and seeing if, all right, do you still feel the same way? And then we find as a result of treating that underlying issue, the attraction has gone down. It's sometimes even have a hard time remembering it. So that's the latest version of what Nicolosi Sr. started. And so it's become much more standardized so that people can't just run around rogue saying they're reintegrative therapists if they haven't gone through the program. And now Joe Nicolosi Jr. has started a certification program. So you can get supervision and become trained in how to actually do this approach. So I would say reintegrative therapy is probably the most obviously standardized and sophisticated, and it factors in a lot from the psychodynamics and trauma-related approaches.
Yeah,
but
no,
it's not the only approach.
Yeah, and there's so many more approaches that we can take, and I'm sure you probably have so much more in your
oh my
slide.
gosh, I knew I was going to have a hard time getting through it all, but this is the latest and greatest. There are other approaches I just can't really get to right now because I know we want to take Q&A, and I know we went long.
Yeah, I know, because there's a lot of people they're saying, Ali, when can I ask my question?
All right, so let me take a break. So that's why I wanted to send you the PowerPoint so that you can send it to anyone who would like to go over more. And I'll send you some links to some other videos of the other approaches as well. So that can be even more helpful. But yeah, if we could take some questions, even I don't know if we're allowed to go past an hour. Do you have the ability to do that?
Yeah, I mean, that's fine. That's
okay,
fine.
good.
Good.
So I don't mind if we go a little longer.
So yeah, so we have actually the first question. So so everyone who's watching, you have the Q&A. So there's like a Q&A icon at the bottom, which you can see. You can also vote the questions, for example, at the moment. Also, you can raise your hand. I know someone has raised their hand, and they've also so I'm going to see if we can
I do see one question in here. So is aversion therapy still being applied now, and is it really effective? No. So, well, first off, all right, let's talk about the effectiveness. Okay, in the 2009 APA Task Force report, they looked at the studies. There were very few studies on the old forms of therapy, which used aversive techniques. And they were not very rigorous, these studies. They reported some change, but there wasn't very much follow through. So we don't know how long lasting any changes were or benefits were. They found some negative outcomes, such as increased suicidal ideation or depression, isolation from family. But the studies weren't very rigorous. So there wasn't a whole lot for them to go off of. Now, our clinical instincts would say it's not wise to use aversive techniques, but there was still some success, and that was reported through these approaches. So I understood why they might have used them in the past, and they were used as part of a repertoire. Like, it wasn't the only approach that these behavioral therapists would use. So just to say that there isn't enough evidence to show how harmful it was, but I would say that pretty much at this point, especially with as the psychoanalysts, they never used aversive techniques. And as psychoanalysis grew into Nicolosi's approach, very psychodynamic and trauma-centered, and actually focused on relieving people of shame. So the very last thing we're ever going to do was try to harm a client. So that became the most predominant therapeutic approach for years. So like I can't think of a single therapist the past 30 years who uses any sort of aversive techniques. Now, is it possible there's maybe some pastoral counselor out there using something like aversive techniques? Like, I don't know, maybe. But we hear these horror stories, but a lot of these so-called conversion therapy survivors will say that they were strapped to a bed and they had cables tied to them and to their genitals and they're electroshocked. Like, who has that equipment? And like, no, and they can't remember who did it. They can't remember the name of this therapist who did this for years. And then they'll say it was a therapist, then they'll change it to as a pastor. It's like it gets more and more someone who's not even an actual therapist that, well, I don't know of any single professional therapist who would do this sort of therapy, let alone approve of it. So no, it just, not to mention, it just goes against what is indicated by the therapeutic model or explanation for the etiology, the cause of the attractions. So if we understand that it's more rooted in unmet developmental needs and trauma, why would you use behavioral approach then? You don't heal from early childhood wounds through being inflicted with pain. So no, it's not being used. It hasn't, as far as professional therapists, haven't been using this approach since the 70s. And I don't know of anyone that's in the Alliance or the Christian ministries, like those in Restored Hope Network, that advocate for it or would tolerate it. If we ever heard of a therapist doing this, we would say, report this person to your licensing board, like make a criminal charge, because there's already rules against torture. So these therapy bans trying to say that people are being tortured, they're based off a straw man. So anyway, so that's one question.
So so the person who's asked that, is that answered your question, brother? I think it's Brother Gober. I think if he's still on. If not, just let us know. But yeah, thanks for answering that, Andy. We've got another question.
How can somebody? Okay.
We've got
okay, this is a good question right here. How can somebody carry out self-help or self-therapy, especially if there are factors which make it hard for somebody to access therapists?
So if we go for the voice question and then we'll go to the audio ones as well. We've got another brother, Abdullah. Brother Abdullah, would you like to ask your question?
Thanks, Andrew, for your enlightening speech and enlightening talk on the therapeutic approaches that are available today. Sometimes I think, okay, what's going to happen in 5 years when there's another form of therapy that happens because I've been in reintegrative therapy now for a while, and it's been incredibly healing and effective. However, one thing I've noticed is that I cannot remember many traumatic. So when we're dealing with these feeling states such as shame and whatnot, I cannot remember traumatic events when I was young. And we know the gender identity phase at the age of 1 to 3, and that's when generally when most traumatic events would have occurred. But I have so much trauma in adolescence that the vast majority of trauma that we've dealt with in therapy have been in adolescence. And it's been helpful, but I'll be honest with you, after so long being in therapy, my SSA hasn't decreased. It's still the same, and it's incredibly disappointing, and I feel very dismayed. So I was told by some individuals after doing a lot of research and reading books of Socrates and whatnot that an individual cannot do reparative therapy if he does not go through psychoanalysis, because he needs to unrepress those repressed wounds as children. So how are you supposed to deal with something which you cannot remember, because the most painful memories supposedly are at such a young age, because that's when the parents' relationship happened with the child. So what do you think of this? Because I mean, there is a lot of people saying that out there that psychoanalysis is the only approach, and we should really revive, some type of combination between the both, so the individual can remember or unrepress those wounds. Because there's so many people who are doing reparative therapy, and they're not coming up with results, even though the third is being said. Sorry for the long question. It doesn't seem to be the case, because I know so many people that have gone through integrative therapy, but the SSA ultimately at the end really hasn't been on a continuum. It hasn't changed. Like it hasn't been static. It's been on a continuum, like you said. It comes and goes. So yeah, what do you think?
Thank you.
That is a good question because, yeah, like I said, psychoanalysis has fallen out of favor so much it's hard to find any actually trained psychoanalysts. There's a couple of points you made there about trying to access the repressed memories. I would be cautious about any therapeutic approach that would tell you that they can help you access repressed memories. What typically we find is that people who have blocked memories, they, even though this probably isn't very encouraging, they'll remember those memories, those repressed memories, kind of spontaneously. So just because there's controversy or debate about implanted memories or a therapist influencing someone remembering things a certain way. So like if you were trying to do, say, hypnotism or something where you would uncover repressed memories, is there a degree that the therapist was influencing you or being suggestive? So most therapists, to avoid being blamed for that, would usually refrain from anything to explicitly try to recall repressed memories. But when we do have people who have recovered memories, it's usually because as they're sort of making other changes in their life, the memories just sort of come on their own as they encounter other triggers. And then we can work on those. So when I've had clients who have like gaps in their memory or blocks in their memory, I don't want to speculate too much. Well, what could those memory blocks include? Mostly I'm just like, let's work with the ones we have. And you've been working on this for 7 months. I'm not sure. I know we'd have to talk more and more, and I think we can do that for sure. And I would definitely be discussing that more with your therapist. And I would probably want to examine or have a frank conversation with your therapist about the therapeutic alliance to make sure you guys are connecting well in a certain way. But like I said, yeah, there's a chance some people may not experience a change that they were hoping for, the change in the desires or the attractions. And so I think the larger question is, will that affect your own value system? Will that then mean that because of the inability to meet the goals that you had, whether or not that was an expressed goal of the therapy, but you were hoping either way to have experienced a reduction in those attractions or that lust, and in maybe the increase or the genesis of opposite sex attractions, and that just didn't occur? What do you do with that? Does that then mean, well, then I'm going to embrace a homosexual identity and relationships? Or you're going to be like, no, whether or not this changes, I'm still going to continue. So you want to be, then some of the therapy will be about, all right, creating a support system that's going to help you with either choice you decide to make. So I hope the therapist is not trying to give you any false hope about the level of change you may experience, or discouraging you from any particular route. It's up to you which way you go with that. But yeah, I would discuss that more and more with your therapist. Like, what may be happening? What else may be holding me back? There's no quick trick. There's no shortcut, I think, to accessing those any repressed memories. I would caution against making that like the holy grail of the therapy process. So, but I hurt for you hearing that, because that's not easy to hear that you've been at this for 7 months and the therapist is apparently using reintegrative therapy, using the latest version of Nicolosi's approach, and you're still not seeing any progress. I would just be sort of taking a pause and talking to your therapist and be like, okay, what's happening? We really need to discuss this more in depth. Is there other approaches I need to take? And maybe, even if you are seeing a therapist multiple times a week. If there's a deeper work you can do and that option's available somewhere, then maybe pursue it. Yeah, I'm sorry. I can empathize with you, but I don't have a firm answer. I'm still learning this stuff myself. I'm actually just started a consultation group with Joe Nicolosi Jr. so I can get trained in reintegrative therapy. But yeah, so I'm still learning this stuff myself. So I don't want to give you too much of like assurance one way or the other, or instruction. But I would definitely continue talking with your therapist about that, about your frustrations with your progress or the changes you would like to see more of. So.
Yeah, no, thank you. And I think it's so important to have that therapeutic alliance where you find that you are getting progress through, and this kind of promise of a change that, oh, it's going to go away, like even if I'm having the most advanced type of therapy, I don't think anyone can promise a change. I think for therapy only can bring about more self-awareness, self-awareness of what's there, but definitely if it's, I think Nicolosi says 3 months, isn't it? If it's 3 months, if you're not seeing progress, then consider changing things and seeing what helps. So hopefully that answers Brother Abdullah's question. We had, I think, Sister Annie.
I'm sorry, I'll just add one thing. Just make sure you have a good support system with you. It makes it so difficult when you don't have other people who are supporting you in your goals and your values. So it's like, okay, I'm going to do this therapy, and then once I experience the change, then I'll be more genuine about who I am, what I'm experiencing, what my struggles are. But I would hope that you would have people that are already in your corner who know what you're going to counseling for and supporting you, and they're letting you know that, hey, whether or not you experience any changes, we're going to love you, we're going to support you. So make sure you have a support system in place, people who really care about just your being healthy and in general, but also that are going to support your values. Whether it's, if you're like, well, whether or not my attractions change, I'm still going to abide by this particular sexual ethic. If that's your sincerely held value, then you want people that are in your corner and also know your struggle, but still accept you. So sometimes we think that, well, I'll just keep that part of myself a secret. And I'm not saying this is your case because I don't know. I'll just keep that private and just discuss that with my therapist. And everyone else in my life, I will try to keep up the front that everything's good, I'm fine, and we'll just try to deal with all the problems in therapy. But I would say things are most effective when you have a whole support system, and therapy is just part of that support system. So just an extra word of encouragement there.
Right. Okay. Now, thank you. So if we go to the Q&A, if there's no any more, actually no, we've got one. We've got
a verbal one.
Brother Faris. Thank you, Brother Abdullah. Brother Faris.
Thank you for your seminar. I have many questions actually. First, I will,
one.
Yes, the latest. I will ask about two major things. Because lately I saw like a comorbidity between SSA and CPTSD, like the complex post-traumatic stress disorder.
Yeah.
And I don't know this because also it's related to narcissism and narcissistic parents, actually mother or father. And sometimes I feel the symptoms are very, very identical with SSA. Like they are, to some extent, they are based on shame, fear, and other issues. Like, I feel like there are some similarities between both of them. And I don't know what are, because even this subject is still new, like CPTSD is still new subject to the psychotherapy. Yeah. And it's still on progressing, let us say. But I see there are many identical issues between both of them. This is first. Second, what about the holistic therapy? Like I know David Matheson before tried to make approach about holistic therapy, but unfortunately he get out. But I mean, it was like, what's the nutrition, for example, role? What is other therapies, for example, brain spotting, IMTT now is good. But I mean, how if these therapies combine together to cover all the dimensions or the factors of SSA?
When you say holistic therapy, what are you including or meaning by that?
I mean, like, it's not only, it's on the body, the mind, because some people get depressed because their gut is, they have physical issues, like their gut is not good, or they have prostate inflammation, or something like the body react also. It's like a vicious circle between the body and the soul and the spirit. And that's why, like, it might be also some issues that are combined with these, with other issues. So we need a holistic approach that all the special people from many specializations, they can see the issue, what's the whole issue about.
Yeah. And also for anyone else watching or listening in who doesn't understand that one acronym you use, CPTSD, that is complex post-traumatic stress disorder. And so it's not, at least in America, it's not an official diagnosis, but for those of us in the trauma-related field, we recognize that as a different form of PTSD, or post-traumatic stress disorder, because we often view PTSD as a reaction to like a one-time event, like it survived or maybe not a one-time event, but a very prolonged event that was dangerous or life-threatening. And say like you were in the military and you experienced warfare. And so then you have PTSD and you're hypervigilant from that. Complex PTSD is referring to the reactions to complex trauma, which is more about prolonged, especially in childhood, prolonged, repeated abuse, neglect. And so we see the effects of that in things like depression, sexual promiscuity, anxiety, hypertension. And yes, when you have, like, there's a study done by the CDC, the Centers for Disease Control and Prevention, called the ACE study, or the ACEs, the Adverse Childhood Experiences. And so they had a lot of family doctors, when clients would come in with complaints about their physical complaints, have them also do a quick survey about their childhood. And they'd find that there's an overwhelming amount of people with medical issues who have adverse childhood experiences as well. So we see that the effects of complex trauma on our bodies. So yeah, an integrative approach would be good. This is where it's helpful when we understand that, okay, so we're not necessarily treating the same-sex lust, the same-sex attraction, the homosexuality. We're not treating that. That's a fruit, that's a symptom. So I find it more helpful to think of that as a trauma reaction. So that's why it's helpful to come from a trauma-sensitive approach and be like, well, this person went through abuse, neglect. They had narcissistic parents, like clinically narcissistic. So, well, what's the approach we would use for that? Yeah, we would use a trauma-sensitive approach. And then as they have consequences with their health, physical health, we might have to use some medication at times to help with some of the trauma reactions or just the effects on their body. Mindfulness-based approaches, better health and nutrition. Inflammation, that's something we're learning a lot about now. It's still very young in the field, seeing how much inflammation affects our emotions, our depression. So that's still a very developing field. So I would say, yes, the best approach is going to be integrative and not just be focused on treating the attractions or the sexuality, but treating the whole person. Like our whole goal really should be for people to just be healthier in general. So I'm all about a truly holistic approach, which is encouraging my clients just to be healthy, period. Oftentimes when I get a client, they'll tell me what their problem is, but then I'll be like, okay, what's your vision for your life? And they don't know how to answer that question. So I'm like, okay, like not just what's your vision or what's your goals for therapy, but like what's your vision for your life? You know, physically, where do you want to be, and emotionally, relationally, occupationally, and I want to treat the whole person and help them grow and develop. And that's a lot of positive psychology going there as well. I'm not sure if that adequately answers the question, because there's still a lot that we're learning about the developments in inflammation and the physical effects of trauma. And so I'm all about us continuing studying that and integrating that into our therapeutic approaches. But we still have a lot more to learn. And so I'm growing in that area as myself.
Right. Okay. Thank you, Brother Forrest. So I just want to go on a quick poll, and we'll take more questions. So you should be able to see the poll now on your screen, as a lot of people are talking about that they have taken specialist therapy or counseling for unwanted same-sex attraction. Even if it doesn't apply, just put NA. So, but it'd be interesting. We've got a few people who have taken therapy. It'd just be interesting to see what. So what we're asking is, have you taken therapy, and if so, has it brought about a sense of self-awareness? And if you have taken it, has it been faith-based, or has it been, someone who's a secular based? So we're just almost through, I think halfway through of people just filling that out. And I think it's just about 76% through. So it's just a poll. You'll see the poll on your screen. So it looks like, at least for the first question, it seems like there's a half-half split between people who have. So it's nice to see. We've got people joining in who've had experiences of therapy, and obviously people who haven't. And it seems like, apart from, for most people, it seems like it has brought about a sense of self-awareness, which I think is so important. And I think what Andrew was saying earlier about recognizing what works for you, what's actually happening. Am I getting a better sense of trauma? What happened to me? Is it, am I better getting an understanding of that? So in terms of question 3, it's interesting to see two people taking a faith-based therapist, and then the majority, or if you've not taken it, taking a secular. And obviously we're in the at least in the Muslim side of things, we're very new to this. So it's probably impossible to find a specifically trained Muslim therapist which will offer some of it, the reintegrative method or Cohen's method. We've got some Cohen's method. For example, in Egypt, there's 2 therapists, for example, who've trained with Richard Cohen's method. But for vast majority, at least the English-speaking Muslim majority, there isn't people who are. So we're very early on in our state, and you can see that by the poll. So thanks for people for voting that. We'll go to the questions Q&A, and I know Errol has his hand up, and we'll go to Errol afterwards. So let's see, we've got the first one, which has 3 likes. How can somebody carry out self-help or self-therapy, especially if these are factors which make it hard for somebody to access therapists?
Yeah. I'm sorry, I saw that question earlier and I jumped to answer it.
It's okay.
Now this may be difficult, but there's a book I would highly recommend by, this is a mouthful, Gerard J.M. Vanden Aardweg. Okay, and the book is The Battle for Normality, a guide for self-therapy for homosexuality. So I did this together with one of my clients. He's mostly coming from a developmental perspective, similar to Nicolosi's, but he emphasizes more the peer relationships later in life, more so than the parental relationships. But so the first section of the book will be development of homosexuality. And then second part is like the last half. So the first half is more just explaining the causes. Last half is a lot of practical steps and tips. And so he would advise going through this stuff with like a mentor who can work with you, not just doing it by yourself. One technique I really liked from it, and it's been a while, it's been a couple of years since I read through this. So but the main one that I took with me that I was just going over this with my client this morning is personifying the problem. Not necessarily the same-sex attraction, but what is the sort of the sub-personality that is emerging that when we're in that sub-personality will influence us to act out in some way. So it's usually a sub-personality that developed in response to unmet needs. So for my client, it was when he felt like he was ignored or he was being treated unfairly as a young boy. So it's like he has this angry little boy sub-personality that would emerge and demand things be done. And so out of that, he wants to do something that makes him feel good. And so he'll go to pornography. And so we call that the angry little boy that rises up and is making demands. No, this is unfair. I want this, I want that. And so he advises personifying the problem. And then another approach he has is using humor. So making fun of the problem, using like talk to the hurt little boy, talk to the angry little boy who is making demands and wants things his way and wants to resolve problems his own way and self-indulge and like mock the little boy. Like this is kind of funny because it's counterintuitive. We usually think, well, you want to do some self-compassion. That's what I typically want to do. But there are times where the angry little boy is being petulant and is demanding. So use some self-humor and not take yourself as serious. So that's an approach he would use. There's a few others in here, of course. But have accountability, have people that you care for that can actually listen to you, hear your story, walk through with you some of the emotional roots. If you have same-sex attraction, I would advise against your accountability partner being another guy that you who also has same-sex attraction, especially if he sort of fits that type that you're attracted to. So I'd advise against that. But you want, within an accountability system, you want peers as well as ones who are older. You want guys who can relate to your struggle personally, as well as guys who can't. You know, guys who can welcome you into the world of men and just treat you like you're a regular guy and can just relate to you on a level as a human and as sort of a fellow man, not just another same-sex attraction struggler. So, but yeah, if you can get a hold of this book, get it. It's just this is one of the books banned. Well, it was banned by Amazon. Yeah. So this is one of the
banned. I got it on Amazon last time. Maybe it is banned now, but
I'm not sure if
it
it's
is
still,
a very good
last
book.
I checked, it was one of the banned books.
Okay.
It's a shame, but you might be able to find it on the black market. Anyway.
Yeah. Thank you for that. If we go to Brother Errol, Errol Hackman, if you're with us.
Hey, can you hear me?
Yes.
Okay, cool. My question is this. One is very short and the other is longer, so if it's okay.
Okay, yeah.
Are there any atheists that practice that kind of therapy?
Any atheists? Okay, so that's the first question. And then the second question.
Yeah, that's a good question.
Second question, the question, have you ever encountered people who experience change towards homosexuality in the middle of their life? not like during childhood or anything, because to me it happened when I was 17. I grew up as straight-ish, and then I experienced some sort of a traumatic event, and it changed for me almost completely. So I wanted to know if you ever encountered those kinds of cases.
Oh, okay. So, yeah, well, you're still, I'm not sure which one. Let me start with the first question, since that was one of the ones I saw in the chat as well. Do I know of any atheist therapists who support this therapy? I can't say that I do. And it's not to say that there aren't any out there, and because this is not necessarily a religious approach. This is just any liberal therapist or psychologist should have no problem with this type of therapy. Any scientifically based therapist should have no problem with it, because if you follow the science, there's nothing that says that this is harmful in and of itself. There may be some therapists who are harmful or unprofessional in their approaches, but to make this a goal of therapy, to explore your heterosexual potential or your sexual attraction fluidity to some extent, is not in and of itself harmful or impossible. So someone being guided by the science should still be open to that. But unfortunately, what we see is there's people follow along lines of politically and religiously, whether or not they'll support this type of work. What's really sad is when we see Christians and other religious people who are against this type of therapy because they've been pretty much duped by the propaganda that's against this therapy out there. But I would say there's no reason why an atheist or an entirely liberal therapist should be against this type of work or wouldn't be interested in doing it. And one thing I'm curious about, I did a video about this on my channel, is the potential for new motivations for guys to experience and pursue sexual attraction change. And what I've been seeing is in response to radical feminism, there's been like this men's movement. And so men are starting to join together in different ways and support each other and actually provide comfort to each other for their wounds they've experienced. And one of the predictions I had was maybe as that is happening, guys who are joining that community and that movement with unwanted same-sex attractions will begin to see, have some of their underlying needs met and start to maybe experience some attraction change or expansion of their attractions and or at least their values, and want to have a traditional family at some point. So there was a video I did about that based off an interview with Benjamin Boyce, and this guy who's a men's rights activist who was living as a homosexual for years and then started to see his attractions change. He would say they expanded into heterosexuality. So not necessarily he had a reversal of his attractions. He probably still, I guess by today's standard, they would say he's bisexual. But he would just say, no, I've expanded into heterosexuality. So anyway, so long way to answer that quick question, but I don't see a reason why you can't, if you're open-minded and just follow the evidence and willing to work with people with their own goals. But I don't know of any, I might know some, I just don't know the faith of everyone I know in this field. There might be some out there. Okay, the other question, you might have to remind me again what that was.
Yeah. Cool.
Yeah, the second question, could you repeat that again?
The question is, have you ever seen a patient who came to you? I experienced the change towards homosexuality in the middle of life. I've always been a bisexual, but more of a straight, much more straight than gay. Now I'm almost exclusively gay, and some days, some rare days, I can feel really strong attraction towards women, but my sexuality had mostly changed for 7 years. Yeah, 7 years.
Okay.
That's
yeah, and you were saying that it was around age 17 that you really experienced this change, or at least more of the influence. And yes, of course, yeah. We would say, so even Nicolosi talked about this, even though his focus was primarily on those who the root issues went back to like age 3. He would call that the pre-Oedipal stage. So he sort of have a certain number of stages, but he was also aware of there being those who developed same-sex attractions later in adolescence. And that also is supported by the research. If you look up research by, say, Lisa Diamond, she's found there's a lot of sexual fluidity in teenagers and young adults in particular. There may be some among older adults, but mostly you see more of that fluidity as you're still developing. So like they've done research where they survey teenagers at like 1 grade, how you sexually identify, and then the same teenagers at a later grade, and their identification changed. And so it fluctuates, or it was in flux. Now, normally the trend was back toward heterosexuality, but either way, what it shows is there's, maybe for lack of a better word, vulnerability to a lot of influence and other changes. I mean, that's your identity formation stage when you're an adolescent. In 17, you're still an adolescent. Even early 20s, I don't like to say they're adolescent, but you're still developing. Your brain isn't even fully developed until mid-20s. So, and we've been delaying adolescence more and more, at least socially. So the expectation to arrive at an identity is being delayed more and more. So the factors there are going to be more peer-related, and at least my assumption would be more peer-related. That would be more of a contributing factor, as well as your environment, and even some ways we react and choices we make in response to experiences. That's always played a role, but we don't like to say that. It's like, oh, so you're saying I chose my sexual attractions. No, just sometimes through our choices, it influences a certain direction. So say you started to engage in homosexual behavior as a teenager, what's happening at that age? You're getting a rush of hormones already as you're going through puberty, and you're also still figuring out your identity. You go and throw in some sort of sexual acts, period, that's going to influence you. So even if we're dealing with people with heterosexual attractions, I don't like to use the term, but heterosexual, homosexual as much, but even with attractions to the opposite sex, you start including sexual behavior at a young age, that has a big impact. So we actually find more healthy outcomes if you delay the one's sexual debut. There's a research that was done, and a really good book by Christopher Doyle that goes into the benefits of delaying sexual debut. You know, putting off experiencing or engaging in sexual behavior. So you got teenagers now that are engaging in pornography, in sexual acts of others, whether it's the same or opposite sex, that's going to influence things. And at the last Alliance conference, one of the presenters, Monica Bro, she was talking about how even through heterosexual pornography, that can end up influencing homosexual attraction, because if you're watching it, you're watching the male for cues of arousal. And so just like Pavlov's dog, you end up getting sort of conditioned to be aroused by the male's arousal as you're watching him engage with the female. So you're watching him and you're seeing him get aroused. And so you're pairing that with your own arousal. So what we engage in can influence us in certain ways. Our environment, the media, those all influence us on top of any trauma or major experience that you had at that age. So yeah, definitely. What I would say is more rare is that you were pretty solidified in your, say, just pure, more exclusively heterosexual attractions throughout life, and then in like your adulthood, like your 30s or 40s, something happening, and then your attraction is radically changing. That I would say is not as likely to occur. But you're still in your teenage years, early 20s, you're still developing. So you're highly influenced at those ages.
I understand. So it's still valuable to explore it. Even when I'm now more of an adult, more of a young adult, I'm 25.
Mm-hmm. You're just now reaching that stage where what we would call now the emerging adulthood. You're like now it's guys, your prefrontal cortex doesn't finish developing until you're 25-ish. So that's several years just prior to now where you are still very highly influenced by your environment, by experiences, by things you view, whether it's pornography, if you engage in any sexual acts with someone, those were highly influential. So what you continue to feed will influence you down the road. So, and also, but not just that, it's also about the level of shame you have with those experiences. Because I worked with plenty of guys who had an experience like a same-sex encounter when they're, say, junior high, and it was not enjoyable to them, or it was even something that they're ashamed of, but they had already enough confidence and security in their gender that they were able to work through that. It might have had some other consequences, but it didn't necessarily develop into same-sex attraction. Whereas other guys, maybe because of some other underlying issues, are sort of primed for that to have the effect it had.
Right. Okay.
There's a video I did on my YouTube channel, I would say, to watch for a little more insight on this, and that's I did a video on Aaron Hernandez and homosexuality. Aaron Hernandez was a football player who killed himself, but he committed murder. And when he was in prison, some of his homosexual behaviors from his past got revealed. And so they did a documentary about him on Netflix, and I did a commentary video about that. So
and there's more videos of Andrew's on PsychoBible which we at the start of the webinar we showed, and I encourage you to watch that. Thank you so yes. Thank you so much, Brother Errol, for your questions. So I guess I want to ask Andrew, do you want to take one more question, or
yeah, you know, we'll take this one right here. I know, I'm sorry guys, my answers are long, and so I apologize about that. But if these remaining questions could be forwarded to me, I can always
we can always forward these to you. Yeah, that's fine.
So the last question is a pretty good one, and that is there's an anonymous person here. Is it worth obtaining a profile of some kind of prospective therapists? Are there therapists available in the UK for SSA related matters, or is it mainly the US? So I would check with a couple sources. I can't give you like names of everyone out there, but there's a couple options I would look into. Check with the Alliance for Therapeutic Choice. The website is therapeuticchoice.com, and they have a directory for approved therapists. It's not so much we don't have a certification program, but they do have preferred therapists and psychologists who work in this field that they would recommend. If you don't see someone in your region, if you're in the US that is accessible, some of them may do online counseling, and maybe contact the Alliance for more options. If you're outside the US, I would check with the IFTCC, the International Federation for Therapeutic and Counseling Choice. It's a new organization, but they're developing and they're trying to get a directory of therapists who do this work. Now, it might not be necessarily available in public on the website, but I would contact them and see if they have a listing of those they recommend. So people who attend their conferences, they're trying to maintain a listing, and now they may not, I'm not sure what the vetting process is for them, but I imagine it would be similar to the Alliance. With the Alliance, they have more of a vetting process where if you go to the conferences, you go to a certain number of workshops that address certain issues, then you can obtain the necessary credentials to be on their preferred provider list. So those are some of the options I would look into first. And then if you can't find someone that's close that you can see in person, check with someone to see if they do online counseling. All right.
Great.
Well, I think
Okay.
that'll be the last question for now. I'm sorry I couldn't get to everyone. And
no.
but also contact Ali. He can send you the PowerPoint since there's more in there. I got into other therapeutic approaches. There's, it's not just reparative therapy. There's also, you can see someone who does cognitive behavioral therapy or narrative therapy, family systems therapy, experiential approaches like psychodrama or support groups, retreats that can help at least kickstart your healing process. So there's a lot of options as far as therapeutic approaches. What I want to make clear is that safety, or what gets mislabeled as conversion therapy, isn't like a single therapeutic approach. We're all just therapists using mainstream counseling approaches. And the main thing is we're following the client and their goals for therapy. What the client is directing the process with their own goals. We're not imposing goals upon them. We're just using therapeutic approaches we would get from any other counseling program that you would get from any other school of thought, and just applying them to the client's goals. So just that's one takeaway I would really like to leave you guys with. I went a little more in depth with, say, reparative therapy and reintegrative therapy, but I had slides to go in more in depth with the other approaches as well. So request that PowerPoint.
Yes, no, we'll be sending that shortly after this webinar. So everybody will have a copy of all the slides. And if you do want to contact Andrew, then just head to strongsupport.co.uk/counseling, where you will see his details as well as other counselors' details that we have over there. Just like to thank Andrew. It's our first webinar, and I know it's his first webinar as well, so he's been patient with us. And thanks, we've had so many attendees. The questions I will email to Andrew, and I'll either put them on our social media or I'll put it on this email list that we have for this webinar, so we're sure that they get answered. So thanks everyone. Thanks Andrew again for joining us.
You're welcome. Thank you, Ali, for the opportunity. Appreciate it.
Thank you. And for the rest of you, we continue with our webinars. So we hope to have a webinar, at least one every month. And for the next webinar, we'd be joined by Sheikh Fazil Soliman, who's from the Bridges Foundation. And he joins us on the, I think, 20th. So we'll be sending details of that out until then. Okay, then. Thanks everyone. Wa alaikum.